Okay. Thank you, Frans and Masi. I don't know what I should say for the 8th time being here, but it's so nice every time, and I really love it. Thank you. I will try to give you some update and we had really hoped that we could present our next update of the ERSPC, the 13-year updating, but unfortunately I cannot today. But I will give you some other new data today from the study, and I will go through some details, and let's see, there are some new things I think it's very interesting still to discuss. It's of course an honor to stand here presenting for you the ERSPC. There are so many involved in this study. Of course, most not least, Fritz Schröder, who initiated this now more than 20 years ago, but there are very many more who should be honored in this enormous study. As you know, started to recruit men in 1993, and up to now, 268,000 men have been randomized, the world's largest randomized study, as I understand. You know all these, that we have an upfront power calculation, and we have had quality criteria for participation for all centers. We have, during the study, have had quality control programs for PSA, pathology, epidemiology, and we have had an international cause of death committee. So it's been really fantastic study to be part of, and very educational too for us who have been there. We have a central database run by Sue Moss in London, and she's currently working very hard. And we also have a data monitoring committee, which now not works any longer as a data monitoring committee, as our main endpoint has been reached. And we also have, of course, National Cause of Death Committee, who have been working in almost all centers except for Finland, who stopped that some years ago. And we have, since more than 20 years, have had biannual meetings. So it must be something like more than 40 meetings now, Fritz, we have met. So we are like a big family. One strength we think with this study, which we have been heavily criticized for, are these differences. Oh, I pressed something. Is there a pointer somewhere on this? Okay, thank you. So as you can see, between the centers, there are large differences. For example, in screening interval, most centers have 4 years, Sweden have 2 years, and also in age at entry, the PSA cutoff, and also the way we have randomized men. So there are large differences, and I will come back to that. This is our last publication, and hopefully soon we will have an update of that. And I will just go slightly through. You all know, last publication we had a 21% relative risk reduction, and the number needed to diagnose was 37, going down, and we saw some larger effect during the last 2 years of follow-up, and we will see whether that will hold for another 2 years of follow-up. In our last publication, this was also published, and as you can see, there are these big differences between centers. You have a relative risk reduction in the Netherlands, is around 30% here, and as you can see, in Sweden is the largest, 44%, while in Finland, which is our largest center, have a rather modest risk reduction, and it gives, of course, a lot of effect on the whole of the ERSPC study. The Finnish study has now been published last year, and you can see they have not reached a significant effect. They have a risk reduction of 15%, and you can see the curves like this. And the number needed to diagnose is at 25 in their study, but as I mentioned, it's not a significant result. But if you look on the participants, which is almost 75% of the men, you see a very much higher risk reduction of 34%, which is a bit difficult to understand as it only 25% of men were non-participants. So those men who were non-participants in the Finnish study must have had a very high rate of prostate cancer mortality. This is I have not the publication in European Urology, but this is the Dutch study, and you can see the relative risk reduction is 31%. It's not very much different, as they have a different, the Netherlands have a different randomization procedure where they have informed consent after, they have a randomization after informed consent, while leading to that most who have consented also participate in their study. Yeah. This is the Göteborg study and the third largest in the RSPC. And you can see here I added the 16-year follow-up data, and you can see that the absolute risk reduction is increasing from 0.34% to 0.38%, while the relative risk reduction is decreasing. But still, the number needed to diagnose is decreasing and is now below 10, which is, I think, in the order of breast cancer screening, somewhere around that. I'll come back to this data soon. Here you see the beauty of a population-based study, because what we randomized directly from the population register, so we can go back and look what was the expected incidence and mortality if we had a situation as it was before the PSA was introduced. This is data from 1990 and 94, and the red line represents the expected incidence in a situation without PSA testing. And as you can see, in the control group, there have been a lot of screening. It did not start early, but it came, and now it's almost a double incidence what it would have been without PSA testing. But the big problem is it have not at all been mirrored in a decreased mortality, or very, very small reduction in mortality. While, of course, in the screening group, who have been invited for testing every second year, you see a large increase here compared to what you have expected. But we also see a large effect on mortality reduction due to this screening. We can also see something else which I think is interesting, that it is, if you look on the number needed to screen and the number needed to diagnose, you can see if you compare to the expected group, you see that it is a false low number needed to diagnose if you compare to your control group, due to the large rate of opportunistic screening you have there. So we can compare them with Finland. As I showed before, the risk reduction in Sweden was around 40%, while in Finland it was just 10 to 15%. So why these two countries, neighbor, and we had the same kind of randomization? Why are they so different in results? And you can see here, Sweden again, control group, screening group. Our control group have followed the expected. If you see in Finland, you see it's not a control group problem, not very much at least. They also followed about the expected mortality rate. But you can see that the effect of their screening is very much less compared to the Swedish screening program. And why is that? you can see here that there are big differences, as I showed you before. And if we can measure this in other ways as well, if you look, for example, the number of PSA tests, the mean number of PSA tests per invited man, you can see it's more than double in Sweden compared to Finland, who only has invited their men 2 or 3 times, while we have invited our men up to 10 times. And the Netherlands somewhere in between. If you then go to the biopsies, you can see the rate of biopsy is very different also. Only 14% of the population was biopsied in Finland, while 24% in Sweden and 36% in the Netherlands. So this, I think, is the explanation to why we see these differences in mortality reduction. I think the Finnish program is less too intense. And it's the same thing we see in the control group in Sweden. This opportunistic screening has not led to any mortality reduction. So I think you have to have a program which has at least some kind of regularity in it. So let's go and discuss another thing. I have some new data on this, and it's the elderly men. Because the older men are the problem. And we know that 75% of all deaths from prostate cancer occur in men older age 75. And half of the deaths occur in men more than 80 years. So those are the men who actually die from prostate cancer. But we concentrate usually on men in the 50 to 60. These are data, what happened the last 15 years in Sweden. It's age-standardized mortality in prostate cancer. And you can see for different age groups. And you can see from 50 up to 75, you can see there is a risk reduction, which is quite remarkable. It goes here from about 100 down to 60, from 200 to 135. And here also quite a remarkable mortality reduction. But look what happened in the oldest man. Nothing happened. Still the same mortality in the elderly man. And these are half of all death in these two groups. Can we do something about it? Or is our screening now effective in this? We looked in our screening study in different age categories, and these are the oldest men, those who were born 30 to 34, and these are the youngest men. And as you can see, if you looked here, we can go down here and don't take all the numbers. We have 38 deaths in the screening group, in this group, and 42. So it's not very big difference in this oldest age group. While it's much more remarkable reduction in this age group and in this age group, even if not have had many events yet. So most of the effects have been in this age group. And why is that? Were these too old when we started? Probably this is one explanation, but there could also be another one. And these are the same, actually. These are curves for those elderly men, and you can see the effect. They're also the expected mortality, and you can see compared to the younger men, it's a much better effect if you start screening early. But this was a paper we published last year, and this is because we stopped screen at age 69. And then we have looked what happened after we stopped screening. And this is the incidence of high risk and advanced prostate cancer. And you can see we have a lower incidence somewhere up here, then they are parallel, and then they even catch up here. So 10 years after you stop screening, you will have the same incidence of high risk and advanced cancers, telling us that the effect of screening is protecting us for 10 years. Not any longer, which I think is a bit scary. Who are dying from prostate cancers are only those high-risk cancers. So I think this is something we have to follow very closely in the future, just to understand what kind of effects we have from screening. So what to expect from ERSPC in the future? As I said, a new update is on the way and hopefully will be published soon. Longer follow-up are necessary, and we probably have to follow this at least for 10 years, I think, because we still have a short follow-up. If you look on time from diagnosis, the median follow-up is shorter than 10 years in all centers. And yeah, what I guess will happen, it's just a guess, but I think the same will happen as in the Swedish center, that there will be an increase in the absolute differences in prostate cancer mortality, while the relative difference probably will not increase or maybe even decrease in future, but future will tell. The conclusions we have from our study is that the effect of PSA testing, it's largely dependent upon how you screen and which population you screen. According to our data, you should not start screening too late, and you should not be too less intensive as in the Finnish program. It seems to be less efficacy. I think at the moment we all maybe could agree about that if a man should have a PSA test, he should be informed about pros and cons, and then of course he should be followed in an organized fashion, not only as it happens in Sweden, at least in Scandinavia, that they come every 5 or 6 years, have a PSA. If it's above 4, we usually make a new control after a year, and so I think we must have a more stringent protocol for it. So this is my personal view. If you choose to test your PSA, do it properly. You should start early at age 50 to 55. I think you should have annual or biannual testing if you not have very low PSA. And you should, at the moment now, the knowledge we have now, you must go on with a biopsy. Maybe MRI in future will help us in selecting patients for biopsy. But if you do not do this, I think you should avoid PSA testing at all, because maybe if you have it too less intensive, you only have the harms of the screening, but not will reach the benefit. Thank you.
Yes, Jonas, thank you very much for this outstanding presentation. It was for me very, very interesting to have a deeper insight in the Finnish data. And to Peter, I want to make a direct comment to this. When I look to the USPSTF, they look to our ERSPC results totally, and I think the ERSPC results can make the message, yes, there is a reduction. Quantification depends on so many inside things that we are not allowed to quantificate the number necessary to diagnose or to screen or to therapy directly so much. When we look to the Finnish data, for example, or they have a regular screening about 19%. It's the highest contamination rate we can have, and opportunistic screening over a longer time. So we have to realize that some centers failed to have an improvement because the individual country situations prevent it. And this is the reason I'm very thankful you show these different messages there. Is there any question from the audience to this? Peter?
If I just can comment on that.
Yes.
We were also afraid about the contamination, but it actually is not the contamination which maybe they have a decrease in Finland compared to the expected mortality. But the problem is that they have a very low effect. Yes. So that their program is have very low efficacy. Yes. And I think what you said is very important. What we have learned is that the different programs have very different efficacy. And that also makes it seems not to be a good idea to combine studies, to have some mean effect. It makes no sense for me.
Peter?
And exactly that. The U.S. Preventive Services Task Force did not look at it as a single trial. They looked at it as 6 trials, of which 4 were negative and 2 were positive. And my question to you, Jonas, the Swedish trial is probably the most positive. We can argue whether it's the Dutch one, but the incidence of prostate cancer, baseline disease before screening, was twice what it is in the US as compared to Sweden. So in other words, Swedish men have a much higher incidence. And how does that impact the performance of the screening test?
I don't know. Of course, it will have impact if you measure, for example, number needed to screen, number needed to diagnose. It will have a large impact if you have a high-risk country compared to a low-risk country. And maybe the effect of screening, I mean, it could make more sense to have a screening for PSA going on in Scandinavia compared to Spain or some of those low-risk countries. So, but I think we are not there yet. We do not understand all this in this puzzle, but it has definite effects.
Right, and that's why I mention it, because there's a dramatic difference between Sweden and the US. So the question, can you immediately generalize from Sweden to the US? And the US Preventive Services Task Force would argue no, there actually has a number of negative trials, and they pointed to the Finnish trial being a negative trial.
But if we look historically, compare Sweden and the US, we not so different. If you look on the risk of dying from prostate cancer, we look 20 years back. The US had about 20–25% lower risk compared to Scandinavia. But if we compare, for example, with Italy and Spain, they have less than half the risk as we have in Scandinavia. So the US men are not so very different from Scandinavia.
Well, they are, because prostate cancer is the leading cause of cancer death in Sweden. Yeah. Lung cancer is the leading cause of cancer death in the US. So the incidence of dying from the prostate cancer is lower. I'm not saying it's zero, but I think it'll affect the performance. And it's a subtlety that many people don't appreciate.
Are there other questions from the audience? Yes, Fritz, please.
Could you speculate what may be the problem with the Finnish study? Because that may be important for all of us in terms of learning how to better apply PSA testing.
I think they have 2 problems for explaining the efficacy. First, they have not screened it tense enough. So they have too many high-risk cancer. Each time they go out, they have too many incurable cancers diagnosed. The second thing is that they have not been that intense in their treatments. They have a bit, especially in high-risk cancer. And it's both for the control group and for the screening group. But I think the key is the high-risk cancers, and you have to reduce the high-risk cancer or find the high-risk cancer early enough so your treatment will be effective. And I think the Finnish study has not been successful in that.
Jonas, I think we made a mistake when we discussed the Finnish protocol, which was coming in later, and that was that we allowed, there were only 3 screens in the protocol, and I think that has another...
Yeah. Some age group only had 2. I think Ove have a question.
But just a question about the Finns. If it's not the efficacy of the screening program and not their treatment traditions or their skills to do the treatment proper, could it be that they have such a high competing mortality because they are known to die pretty fast in cardiovascular diseases, so they will not live long enough to benefit from their prostate cancer treatment because they will have to live for like 10 to 15 years after we diagnose them?
I see, for example, have a very high rate of only hormonal treatment in men. For example, if they have a 60-year-old man who had a T3 disease, they only have hormonal treatment, nothing else, even if they have no metastases. Yep. Some Gleason 8, T2 were also treated only with hormones. So they have a high mortality rate in both arms in prostate cancer. So I don't know whether it's an old tradition in Finland that you do not treat that aggressively. But nowadays, they do not have so many cardiovascular events as they used to have because they're treating that better.
Even though they use estrogens and GnRH analogs.
I think they stopped.
Okay.
You mentioned the more aggressive disease or aggressive disease in the older patient, and I have a question. We have a real problem right now at the Martini-Klinik in Hamburg. We try to select our patients very carefully in respect to the cancer, doing active surveillance in the low-grade or in the low-risk group, and of course in respect to the age and the life expectancy. So the mean age still is 64 and 80% are younger than 70. But now we see more and more patients in the early 70s in good health with longer life expectancy with very aggressive tumor.
Yeah.
So we are not sure that we should limit our local treatment to an age, let's say 74 or something like that, what we have done in the past. It's a real problem in our daily practice. Can you comment on that?
Yeah, I think it makes much sense. It's much more sensible to make a radical prostatectomy on a high-risk cancer of a 75-year-old man than doing a radical prostatectomy on a low-risk cancer when he's 60. So I think, but the problems with screening is how should we detect them? Because we cannot screen up to the age of 80 because we will find a massive, enormous amount of low-risk and intermediate-risk cancer while we screen to find those with high-risk cancer. So that I think is a challenge in future for I think we have to...
And this will be the next topic by Fritz.